Perfect. All right, so welcome everyone. And it's definitely exciting to be here again in person. Just as an announcement, so for this month, Grand Rounds, next week will be Dr. Zubin Master from Mayo Clinic. He's an expert on biologics and the appropriate use and counseling. That will be completely Zoom-based, so no in-person session. We will have a session with him at 6:30. That should be interesting discussion, followed by his Grand Rounds talk at 7:30. Totally Zoom for that one. Don't come here. And then the following week will be Dr. Rhonda Watkins, and we will be in person for that session. And then so for today, it is my pleasure to introduce Dr. Leah Demetri. Dr. Demetri is one of our fourth-year residents, and she's originally from the East Coast, came out to Stanford for undergraduate, and then went back to the East Coast to Harvard for medical school. And then she was able to join us for residency. She's been a fantastic resident and then pursuing a career in hand surgery. She's had a number of funded research projects, won a number of awards, and then her strongest interest has really been in education. And I think you can see that this started early on. She was active in medical school and curriculum development. She's been an active member of our orthopedic surgery residency committee. And she will be speaking to us today on surgical education. So Leah, thank you so much for speaking, and look forward to your talk.
Good morning, everyone, and thanks for the introduction, Dr. Lansdowne. Today, I'm going to be talking about surgical education, which has been a longstanding interest of mine. Dr. Levine was here just a few short weeks ago at our Inman Advocate conference, and he really laid the foundation for this discussion. So today, I'd like to build upon the principles he established and discuss tangible ways that we can improve surgical education. Although I have no financial disclosures, I have the bias that my viewpoint is one of a resident. So although I do consider myself both a trainee and an educator, I've not yet had the privilege of being a faculty educator. That said, I hope to present data from the literature today that is relevant to all of the trainees and the educators in the room. So before we get started, I'd like to make sure that everyone's awake this morning, and I'd like to take stock of how we're doing in our own department here at UCSF. Obviously, this is anonymous, so I hope you feel free to answer honestly, and I also hope that those who are joining us via Zoom can participate as well. So if you can go to www.menti.com and use the code that's listed on the screen, it's 953-27-306. So I'm going to ask a number of questions, some of which are for faculty, some of which are for trainees. And this first one should be easy. Are you a faculty or a trainee? So I'll give everyone a few minutes here to log in and make your selection. All right, I'll give us another few seconds here. It looks like we're still getting more responses. Still going, so let me give another like 15 seconds. Yeah. Maybe some of you weren't prepared for this, so you have to get out your phone or your computer. Okay, I think we've plateaued here. Okay, so this question is for both faculty and trainees. How often do you discuss learning goals at the beginning of a rotation? Oh, we have some unknowns. They must have registered late. That's okay. Okay, so summarizing what I'm seeing so far, and you can see that the data here is stratified by faculty and trainees. It looks like we have quite a wide distribution. We have a good number of people who will say almost always that they're consistently doing this, although a greater percentage of that is faculty. It looks like most trainees think that this is happening about half of the time. And still a pretty substantial number of people, both faculty and trainees, think that this is happening infrequently. Okay. Another question for both faculty and trainees. How often do you discuss learning goals at the beginning of a case? All right, so it looks like our results are pretty clear here too. Interestingly, the almost always category has gone down compared to at the beginning of a rotation. I guess similar to the first question, it's mostly faculty who think this is happening almost always. And then the majority of trainees are saying that this is happening quite infrequently at the beginning of cases. And that's the largest group by far, with 22 people in the infrequently group. Another question for both groups. How often do you discuss trainee competence for a specific procedure? So for trainees, that's if you're discussing your competence on a procedure, say with your faculty or your senior resident. And for educators or faculty, how often are you discussing trainee competence for a specific procedure? This is kind of interesting watching these three questions in succession, because I think we're moving a little bit down towards the left. So we have many fewer in the almost always category, and we have a lot in the infrequently. Interesting, it looks like actually the faculty are pretty evenly split between these categories, but definitely infrequently is our largest category here. Okay, this question is just for faculty, so trainees, don't worry, the next one will be for you. What percentage of new fellows arrive capable of operating independently for simple cases? Okay, interesting. So the largest group, I'm surprised by this, but we'll talk about it more later. So the largest group here is saying 0 to 25% of the time fellows arrive prepared to operate independently for simple cases. Okay, and then this is our specialty specific. Okay, yeah, thank you for, I didn't qualify here whether I was talking about general orthopedic procedures or specialty specific. Okay, and then one final question. This one's just for trainees, and you'll have to click like next slide on your screen, otherwise it won't advance. So just for trainees, how often is your level of autonomy in the OR equivalent to your expectations for your PGY level? Oh, not for faculty to answer this one. Okay, so it looks like we have a clear winner here. Trainees think that this is happening about half the time, with small groups in the infrequently grouped and the almost always. Okay, so I'll try to reference these as we go on, but hopefully this gives us a little bit of food for thought. So why should we be talking about surgical education? Well, if you didn't already know, a quick Google search will tell you that UCSF is one of the best orthopedic surgery residency programs in the country. But I didn't need Google to tell me that. I chose to come to UCSF for my orthopedic surgery training because of the incredible emphasis on this department in education. The faculty are some of the most dedicated and talented educators I've ever met, and the residents are hardworking and engaged. And our graduates go on to become leaders in orthopedic surgery. We're also innovators. We're leading the way as one of the most diverse departments in the country. We're moving the needle with unprecedented research. And we're setting examples for outstanding clinical care and global outreach. So it follows naturally that we're uniquely poised to be leaders in orthopedic education. And it's certainly not easy. The healthcare landscape has drastically changed over the last 30 years. Many of these changes are valuable, but they often have unintended consequences on education. So my goal today is to define 3 major challenges in surgical education and to discuss concrete solutions. These challenges are not unique to UCSF, nor even orthopedic surgery, but I think we're the right people to take on the challenge. This talk certainly isn't comprehensive, and that's not my aim. I hope you'll walk away from today's talk with tools that you can immediately apply into your everyday practice, both as a learner and an educator. Some of the challenges I discuss will also require systemic change, systemic reforms to address. And these are important topics to think about. But there's also some really low-hanging fruit that we can capitalize on. So I'll try to focus on these solutions in particular. So quickly, let's go through each of the challenges. So challenge 1 is aligning faculty and trainee goals and expectations. Challenge 2, creating deliberate practice using constructive feedback. And challenge 3, training residents for independent practice in the current healthcare landscape. Let's start with challenge 1, aligning faculty trainee goals and expectations. So looking at our Menti results, it looks like we have some varied opinions about how we're discussing goals and expectations, at least right now. Here's a common scenario that may seem familiar. An attending and a trainee are about to do a case together, and they're waiting for the patient to go to sleep. They haven't actually talked about the case yet. And the attending is thinking, I wonder if she's ever done this surgery before or what she's read. Does she know what plate we're using? The trainee is thinking, I probably won't get to operate today, so I didn't make a pre-op plan. I'm not sure what I'm supposed to learn from watching. So what's the problem? Well, both parties are disappointed. The attending doesn't know if the resident is sufficiently prepared, or maybe they're worried that they're not. Residents' expectations for hands-on involvement are not being met, and their learning objectives are unclear. So what can we do about it? Well, we can set goals together and discuss realistic, explicit expectations. This isn't rocket science, I know. And the truth is we probably all know that having discussions at the beginning of a rotation or at the beginning of a case would be good. But it takes time and we're busy. So let me convince you that taking the time to do this will not just make us happier because we're on the same page, but actually help us train and become better surgeons. Let's dig into goals a little bit further. Why do they matter? Goal setting theory was initially proposed in the 1970s by Thomas Arthur Ryan in his book, Intentional Behavior. Ryan's theories have been further developed by Edmund Locke, a psychologist who's published extensively on the topic. His research can be summarized into 2 key findings. Setting specific goals leads to higher performance than setting non-specific do your best goals. So for example, saying I want to earn $500 a month is more effective than saying I want to earn more money. And number 2, harder goals result in higher performance. The natural follow-up question is, does this apply to surgical education? Well, we have the literature to show that it does. This is a study published in the American Journal of Surgery in 2016. The authors looked at third-year medical students attending a boot camp in knot tying and camera navigation. Each student was assigned to a specific goal, either do your best, a performance goal, or a learning goal. Do your best is what it sounds like. The performance goal was that students were told to finish the task in 45 seconds. And the learning goal is that students were told to master the task, but without a specific time objective in mind. Videos of the students performing the tasks were recorded and graded, and performance at the beginning and the end of the intervention were compared. You'll see that performance differed based on the goals that were set. Those who set learning goals improved the most, followed by performance goals, and finally, do your best. So hopefully I've convinced you that setting goals and expectations will improve performance. So how do we implement it? Well, setting goals should be a collaborative process between trainees and their educators. And the good news is our faculty have already put together goals and objectives for each of our resident rotations. Here's an example from the hand service. So this can be step 1, emailing out a document. I'm not sure if it's happening universally right now, but it's easy enough to implement. But I think this is only step 1. To be effective, goals should be specific to the individual trainee because everyone has their unique strengths, weaknesses, and even aspirations. So this leads us to step 2. The trainee should review the document and formulate their own specific individual goals. Now, step 3 is arguably the most important, building a relationship together and having a discussion about it. In person is ideal, but on the phone could work as well. Educators can provide input on whether the goals are appropriate and make sure expectations are clear. This process works well for attendings and residents, but this is also a great opportunity for senior residents to mentor junior residents as well as medical students. So who should initiate the meetings? This is important to define because if both parties are given an opportunity to initiate, often neither one will, and we probably know that well. Trainees should take the lead here to be proactive about their own education. With near-peer mentoring, it's possible that maybe senior residents should take the lead here in case junior residents or medical students aren't aware of the culture of goal setting. Let's talk a little bit more about step 2, because setting appropriate goals takes practice. The most important thing to remember is that goals should be specific. Objectives should describe what a trainee should be able to know or do as a result of a learning experience. Bloom's taxonomy is a great way to think about categorizing goals. It divides cognitive skills into levels of complexity, starting with the most basic, remember, going to the most complex, create. Each level is associated with verbs, concrete tasks that you can strive to be able to do. So let's look at a few examples. For a PGY2 on sports, they may set a goal at the first level, remember. For example, they may want to be able to define treatment options for rotator cuff tears. For a PGY4 on sports, they're much more advanced, so they're setting a goal at the top level, create. For example, they want to be able to formulate a treatment plan for a patient with rotator cuff tear based on the patient history, exam, and imaging. Let's look at a few more examples. In this case, you're a PGY2 at San Francisco General Hospital. You want to define the steps of cephalomedullary nail placement, explain the Loggy-Hansen classification of ankle fractures, and you want to be more efficient in the ED. Didn't we all as PGY2s? So let's reframe this last one because it's a bit vague. How about start writing notes while talking to consultants on the phone and gather splint supplies before seeing a patient so you're ready to go when you get to their room? How about goals for a PGY5? Well, at this point, you want to be able to perform 2 cephalomedullary nails independently, and you want to ensure that 90% of block time for your service is filled. And on top of all that, you want to be a good mentor to medical students and junior residents. But again, that's very broad, so let's reframe it. How about organizing 3 feedback meetings for each trainee and 2 social bonding events? So what does this look like in real life? The good news is it's already happening. And here's one example from earlier this year. And I could pick from many other examples of conversations I've had. Hi, Leah. I'm super excited to work with you this upcoming block as co-residents on this team. Would love to hear about your academic and personal goals for the upcoming block and how we can work together to achieve them. Brilliant UCSF Orthopaedic Surgery Resident. I emailed all my goals and received point-to-point feedback on each of them. We also discussed this in person, but having it written down was a helpful reminder for later in the year. But here's the key, we actually followed up. 3 weeks into the block, we checked in again and went through each goal, whether or not it had been achieved, and if not, how I could work towards achieving the goal in the coming weeks. Finally, we checked in at the end of the rotation one last time to debrief. It only took about 5 to 10 minutes for each conversation, but it went such a long way towards developing a relationship and maximizing opportunities for me to reach my goals. So is goal setting at the beginning of a rotation enough? Goals can be set even more regularly with each case in the OR. A really easy structure to follow is an educational timeout, just like we do surgical timeouts. This was a study published in the Journal of Surgical Education in 2019. The authors proposed a short conversation between the trainee and the attending at the start of each case. This can be done while waiting for the patient to be put to sleep or even at the scrub sink. First, what step of the operation does the trainee want to focus on? Again, this helps create a specific goal for that case. Second, what is the trainee's current competence level? And finally, what techniques or strategies can the trainee use to reach that goal competence? Using this structure, the authors found that preoperative goal setting increased from about 35 to almost 80%. Both residents and attendings agreed that this improved the educational experience, and they felt that the timeout helped identify deficits, increase autonomy, and increase receipt of feedback. One final note is that it's important to set realistic expectations here. If the resident says that their goal is to independently ream the acetabulum with supervision only, and the attending plans to ream the acetabulum themselves, this is a great opportunity for the attending to suggest that the resident focus on how the attending places acetabular retractors so that they get appropriate exposure. And that way, the resident is more prepared to do that step next time. If you don't like the idea of going through 3 questions, this study looked at discussing a single question preoperatively. What are your goals for this surgical case? With just this one question, residents felt they were better able to maximize learning opportunities and were more satisfied with their participation in cases. So let's summarize what we've discussed so far. The solution to this problem is simple. Set clear goals and expectations. Schedule a meeting at the beginning of the rotation to discuss goals. And at the beginning of each case, perform an educational timeout with these 3 questions. Or if that's too much, just discuss your goals for the case. This should take no more than 5 minutes. In reality, the main barriers to this are time and initiative. Trainees need to be proactive in scheduling these conversations and bringing goals to the table. Faculty need to respond by being available and defining clear expectations. And although it requires effort up front, these strategies should improve satisfaction of both the attendings and the trainees, as you'll be on the same page and better able to function as a team. So let's move on to challenge number 2, creating deliberate practice using constructive feedback. Now that we've set the stage with goals and expectations, we're ready to assess how we're doing. This is where quality feedback comes in. I know feedback is a buzzword, and many of you are probably rolling your eyes thinking, I can't bear to sit through another talk on feedback. But I think this is some of the really low-hanging fruit that we can improve on in education. And I hope I'll convince you of this by the end. And just going back to our Menti results, it sounds like very few people are having conversations about competency. So all the more reason that I think this is important. Here's another real scenario. I looked at my own evaluations on MedHub and collected some for my co-residents. The end of the evaluation is focused on constructive feedback. And here's what I found. Suggestions. Continue to seek learning opportunities. None. Keep up the strong work. Continue current path. Listen, ask questions, read voraciously. None. None specific. Continue reading about orthopedic surgery. So what's the problem here? Trainees often don't take the initiative to seek out constructive feedback. And when they do, the feedback they receive is often not specific. Multiple research studies have shown that the rate at which surgical trainees receive constructive feedback is about 30%. So why does it matter? Well, feedback improves performance. Kay Anders Erickson is a psychologist at Florida State University, and he's written extensively on how to become an expert. So that could be a professional athlete, a musician, or a surgeon. If you're interested in learning more, he wrote a great Harvard Business Review article. But to summarize the bottom line, becoming an expert requires deliberate practice. And this involves a well-defined goal, feedback, and ample opportunities for repetition. And don't forget about Locke, the psychologist who defined modern goal theory. Harder goals result in higher performance. If you're meeting all of your goals, you need to set new ones. Everyone has the capacity to improve. So if you're having a feedback conversation and the educator says, you're doing great, I have no suggestions, the trainee's goals haven't been lofty enough, and the educator hasn't been observant enough. We had a fantastic grand rounds in 2019 by Calvin Chow, in which Dr. Chow laid out the framework for how to give feedback. The talk was recorded, so if you want an in-depth review on how to do this, just ask Dan Peterson for the link. But for today, I'd like to review a few of his key principles. Learners are more likely to follow up if they say constructive feedback themselves. Dr. Chow teaches us the art of feedback. Ask, reflect, tell. If you think 3 steps is too many to remember, which to be honest is how I felt at the time, just remember to ask. For the most part, learners are extremely insightful and self-aware. This will make the conversation less awkward because the trainee has already identified their weaknesses. But I remember thinking during Dr. Chow's talk, that's all well and good until you have a learner who's really off track. What do you do then? His advice was simple: ask again. Ask why you think they have excellent suturing technique or why they think their preoperative plans are top-notch. Then follow up with, can I share some of my observations? And then you can start working on getting on the same page. So how can you incorporate this into your everyday practice? Just like we do a surgical debrief at the end of each case, you can add an educational debrief. Use 2 simple questions. What went well and what could you do better? Dr. Ding is an expert at this. He reliably asks these 2 questions at the end of every single case. And these questions have actually been studied. Research has shown it's easy, effective, and takes less than 5 minutes to discuss. In addition, as Dr. Levine suggested a few weeks ago, we ought to be having 3 meetings per rotation. One at the beginning, the middle, and the end. The first meeting can be used to discuss goals and expectations, and the other 2 meetings can be used to discuss feedback and performance. Luckily, you can use the same format for all of your feedback conversations. One new tool that may help us improve feedback even more is the ABOS KSB program, which our program plans to implement in the next few months. KSB stands for Knowledge, Skills, and Behavior Program, with the premise that surgical competency requires expertise in these 3 fundamental areas. Knowledge is already assessed with the OITE, a written exam that we all know well. And the new addition is that surgical skills and professional behavior will be assessed using surveys administered to faculty online. The surgical skills component is designed to be filled out twice a week, immediately after a case. There are 8 questions that focus on specific aspects of the case, from preoperative planning to technical performance. For each question, faculty rate the resident based on the level of autonomy, from the attending had to do it themselves to the attending didn't need to be there. There's also a summative component. Is the resident able to perform the procedure independently, yes or no? The focus of the KSB survey is on competency. And the good news is that fits in well with the strategies that we've already discussed so far today. At the beginning of each case, we discussed having an educational timeout where you can discuss the goal level of competency. So the KSB allows us to evaluate competency at the end of the case. How can we use the KSB program? Importantly, these surveys should not be a replacement for face-to-face conversations. Remember that the most effective constructive feedback starts with a self-assessment, with the learner assessing their weaknesses. But this can be a useful tool to help make your feedback even more specific. You can use the questions on the survey to identify areas that are actionable for improvement. And working on these goals will improve progress towards competency and graduated independence. So let's summarize challenge number 2. Luckily for us, the solution involves at least what I think is low-hanging fruit. Collaborate frequently to discuss constructive feedback. Remember the art of giving feedback: ask, reflect, tell. The emphasis is on the ask, and you can use 2 simple questions. What did you do well, and what could you do better? I should add in here that learners should feel empowered. If your faculty don't explicitly ask you these questions, you can ask them yourself. Self-assess and then ask for feedback based on your self-assessment. Discuss feedback at mid and end of rotation meetings, as well as at the end of each case, just for 5 minutes. And when the ABOS KSB surveys become available, take advantage of them to make your feedback even more specific. But don't let it replace face-to-face conversations. Let's move on to the 3rd and final challenge: training residents for independent practice in the current healthcare landscape. And again, going back to our mentee survey, there were some varied results on whether or not fellows arrive ready to perform surgeries independently, although, as Dr. Briven pointed out with the good caveat that I didn't specify specialty specific or not. So here's one more common scenario. While the picture shown here is certainly an exaggeration, there's no doubt that our current healthcare system has dramatically decreased resident autonomy compared to 30 years ago. Is this a good thing? Is this a bad thing? Does it matter? The question we really need to answer is whether or not graduates are ready for independent practice. While there's not much data on this in the orthopedic literature, general surgeons have been studying this for a while, and their results are quite alarming. This is a landmark study from the general surgery literature that's been cited over 600 times. In 2013, the General Surgery Fellowship Council sent out a survey to all of the subspecialty fellowship program directors to assess the preparedness of incoming general surgery fellows. They received 91 responses. To highlight a few of the key findings, they found that 30% of fellows could not independently perform a laparoscopic cholecystectomy, which is one of the most common general surgery procedures. Furthermore, 66% were deemed unable to operate for 30 minutes unsupervised during a major procedure. Here's another study looking at the readiness of US general surgery residents for independent practice. It was published in the Annals of Surgery in 2017. Attendings at 14 general surgery programs were trained on how to evaluate residents using two different scales. One was the Swish scale, which is a measure of resident autonomy, and the second, a performance scale, a validated measure ranging from critical deficiency to exceptional performance. Graduating residents were expected to have an autonomy level of either passive help or supervision only, and performance was expected to be either practice ready or exceptional. A total of 400 attending surgeons evaluated 500 residents on over 10,000 procedures, so that's a lot of data. They found that more than 10% of graduating PGY5 residents demonstrated inadequate performance and insufficient autonomy for 4 out of the 5 most common general surgery procedures during their last 6 months of residency. So you can see on the graph on the left, it's showing autonomy, and anything in blue is considered inadequate for a graduating resident. Same thing on the right, and I've highlighted the 4 common procedures in which more than 10% of the graduating residents were deficient. To the right of the red line in each graph is listed the other core procedures that graduates are expected to know, as well as non-core procedures. And you can see that there's a large deficiency in each of these categories as well. So why might graduates not be ready for independent practice? Well, many changes in our healthcare system have posed unintended consequences on education. Let's go through a few of them to help understand the unique challenges that we face today in training surgeons. The first is increased scrutiny of surgeons and a public focus on patient safety. I put patient safety in quotes because I'm not convinced that patient safety is necessarily being compromised, but there's no doubt that the public lens has decreased resident autonomy. One potential unintended consequence of this could be a risk to future patient care if surgeons are not trained adequately. The next is an increased focus on surgeon productivity, specifically RVU-based reimbursement. This puts pressure on surgeons to increase their operative load and efficiency on the OR, leaving less time for teaching. And finally, work hours restrictions have led to decreased clinical exposure and therefore decreased opportunities for autonomy. These restrictions can also lead to a shift work mentality and ultimately the loss of personal responsibility amongst trainees. This is a vicious cycle, further contributing to the loss of clinical exposure and autonomy. I'd like to dig a little further into public mistrust because I think it's a topic that we don't discuss often enough. One recent study published last year assessed public perception of general surgery resident autonomy using surveys. They found that only 21% of the public thought that PGY5 residents should be operating at a level of supervision only. But as a reminder, supervision only is the graduation expectation for surgical residents. So there's an important disconnect here. Additionally, when you ask at what level of training would you allow a resident to be involved in your case, 30% of people responded that they would not allow a PGY1 or 2 to be involved in their case. And that includes 7% of people who refuse any trainee involvement, including PGY5s. Why is the public so fearful of resident involvement? while 1/3 of respondents thought that if a resident was involved in their operation, they were more likely to have a complication. Is this true? Well, I dug into the literature a bit to try to find out. Interestingly, the VA offers a unique opportunity to study this because their medical records document the level of resident autonomy for every operative case. The categories have changed a bit over the years, but nonetheless, resident autonomy is captured. For example, the levels range from the attending performing the procedure to the attending assisting the resident, and the attending not scrubbing, and finally, the attending not being in the room. In 2005, a study published in the American Journal of Surgery looked at this data and found that resident-only cases, meaning that the attending was available but not present in the room, had equivalent 30-day morbidity and mortality to cases with higher levels of resident supervision. This study was repeated recently and just published in March of this year in JAMA Surgery. The authors found very similar results. They compared resident-only cases, attendings not scrubbed, to cases where the resident was assisting and attending, and finally, when it was only an attending operating alone. Similar to the 2005 study, they found no difference in morbidity or mortality. They did find that resident-only cases had longer operative times compared to attending-only cases, although interestingly, they were still shorter than attending plus resident cases. So now that we're armed with some data about our changing healthcare landscape, let's revisit these challenges and discuss potential solutions. I want to be transparent here that we're transitioning away from the low-hanging fruit that was the focus of the first part of this talk. These solutions involve systemic changes that we need to support at a higher level, but as leaders in education, I think that's our role. So to address the increased focus on patient safety, one step we can take is to mitigate public mistrust through patient education. And at the same time, we can ensure safe graduated autonomy by assessing competence. The study I mentioned earlier, looking at the public perception of resident autonomy, astutely pointed out that we as surgeons are usually not very forthcoming with patients about trainee involvement. They wrote, for example, we might counsel the patient that a resident surgeon will be assisting us during the procedure, but anecdotally, it's rare to discuss in detail how much autonomy the resident will be given. Fortunately, some surgeons have already started to look at whether patient education can help. This study was performed at the University of Texas in 2018, and they found that patient education of trainee involvement using an informational video in clinic improved willingness to allow a chief resident autonomy. They found similar results in another study using an informational pamphlet instead of videos. Safe graduated independence requires accurate assessment of trainee competence. Although many surgeons are already very skilled in this respect, I'm hopeful that the objective measures, such as the ABOS KSB surveys, can help improve communication about competence and therefore help trainees work towards readiness for independent practice. Another important factor in surgical education is diminishing time to teach. And one potential solution is changing the way that educators are reimbursed to align with educational goals. A study published in the New England Journal in 1996 looked into how teaching faculty and departments are reimbursed for teaching time. So although this study was carried out in the Department of Medicine, I think its findings are still relevant to a surgical department. They found that 80% of the faculty members were teaching for more than 137 hours per year, and that the department was being reimbursed $16 an hour for that time, concluding that the teaching efforts are poorly compensated. Would compensating teaching improve education? Well, a recent study published in January of this year looked at the effect of salary compensation on teaching in an orthopedic surgery residency program. They use an indirect compensation model in which teaching faculty have reduced productivity expectations in terms of RVUs, but receive the same salary as their non-teaching peers. They compared teaching effectiveness between faculty who are compensated for teaching and those who are not, using a validated assessment tool, and they found that teachers who were compensated for their time demonstrated a markedly higher composite teaching effectiveness score. So if education was going to be compensated at least more than it is now, the obvious question is who should pay for this? Is it the department, the institution, This is obviously a very complex topic, but one that warrants further discussion. Dr. Levine spoke about how millennials like to train smarter, not harder, and perhaps that's how we should think about reduced work hours. One potential solution is to incorporate innovative learning tools such as simulation. And at the same time, if we're going to spend less time together, we have to go back to the basics and make sure we still find ways to build trust between faculty and trainees. In an era where hands-on training is often limited, simulation, such as virtual reality training tools, presents an incredible opportunity to augment surgical training. There's a substantial amount of research that supports the use of simulation for building arthroscopy skills. For example, this study published in JBJS in 2008 randomized junior residents to either benchtop simulators or no additional training. All of the residents then observed in the OR and were given instruction on how to perform a diagnostic knee scope. They subsequently performed the diagnostic knee scope under supervision, and their performance was graded. And as you can see in the graph, the performance of the simulator trained residents was significantly better than those who were not simulator trained. Virtual reality has also provided promise as a teaching tool for surgical skills outside of arthroscopy. So here's one example from a recent study published in 2020. 18 residents were randomized to one of two training modules on performing a reverse total shoulder, either virtual reality or watching a technical video. Knowledge and technical skills and the ability to perform the procedure were assessed in a cadaveric lab, and performance was evaluated using a standardized assessment tool. They found that training with virtual reality resulted in better knowledge, better efficiency, because the trainees completed the training almost 400 times faster, and higher performance. Many studies so far, at least on virtual reality, have focused on knee and shoulder arthroplasty, so future research would be needed to investigate whether virtual reality can be effectively applied to other aspects of orthopedic surgery, such as hand surgery. But already we're starting to incorporate these tools, such as the arthroplasty service, using virtual reality on their service. And to bring us full circle, while cost may be a limiting factor of virtual reality, building relationships is free. With decreased work hours and growing departments, it's crucial that we find ways to build trust between trainees and educators in order to provide a strong foundation for educational success. So to summarize challenge number 3, I admit that there's no quick fix here. Our changing healthcare system poses significant challenges in surgical education. However, we can start by addressing public mistrust and advocating for safe graduated autonomy. We can consider changing reimbursement to align with educational goals. And finally, we can incorporate virtual reality and other simulation techniques, as well as building trust. So putting this all together, today we've discussed 3 major challenges in surgical education. I hope that regardless of whether you're a trainee or a faculty, you'll feel equipped after leaving Grand Rounds today with some concrete tools that you can immediately apply into your everyday practice. To start, have 3 face-to-face meetings during every rotation. Make this a priority. Residents should initiate, and faculty should make time. Discuss your goals and expectations, evaluate competency, and practice deliberately by incorporating constructive feedback. Perform educational timeouts as well as educational debriefs. Discuss goals at the beginning of each case, and post-operatively discuss what went well and what could have been done better. Use the ABOS surveys as an adjunct when they become available. And finally, advocate for systemic change to address our changing healthcare landscape. This includes addressing public mistrust, changing reimbursements to align with educational goals, and incorporating simulation and virtual reality. There's several thank yous I want to extend to my incredible fiance who keeps me grounded and gives me insight from outside the medical lens, to my mother, who's an internal medicine medical educator herself and certainly inspired my passion on the topic, to Drs. Feely, Toogood, Diab, Schroeder, Bing, and Lansdowne for spending hours discussing these ideas with me and having the courage to give me constructive feedback. And finally, thank you to my fabulous co-residents who support each other, have fun together, and encourage me to be a better doctor. Thanks.
Thank you, Dr. Demetri. That was excellent. I think reflects a lot of things that we can improve upon. If anyone has any questions, I can pass around the microphone. And then if anyone on Zoom, please turn your video on. And then if you have questions, you can unmute yourself and take those as well.
You can keep it. You can ask for me.
Okay.
First, busier rotations. Who do you suggest residents meet with? All of us, some of us. That could be hours of meeting for AJ. He might never make it to the OR by the time he finishes 3 meetings with 7 faculty.
That's a great, yeah. The question is with, busy rotations and growing departments, who should the residents meet with on their rotations? Should they meet with one faculty member? Should they meet with everybody? How do I suggest that we tackle that? So that's a great question. And I think this is where having designated people who are the ones really focused on education is important and would be most successful. Because you're right, we don't have time to meet with everybody, and that probably wouldn't be valuable. So I think designating maybe the one person for each service that is going to be the focused person on education can focus on these discussions would probably be best.
That was great. Thank you for reminding us about the low-hanging fruit. And the really hard part of this that in academic settings, and you've alluded to it, we set aside is the patient. We talked a little bit about the public, but on any given day in the operating room, there's me, the resident, the fellow, and then there's the patient, and we have a conversation with the patient. And we're not very detailed about who's doing what part of what procedure, and you've thought about this a lot, and it'll weigh on you even more heavily in a couple of years when you're having that conversation with the patient before they come into the operating room. What are your thoughts about the patient's role in making decisions about this? I've heard some say, oh gosh, particularly anesthesia, if the patient doesn't agree to let the resident do the spinal, then they can go somewhere else. Well, that's kind of not how in our specialty we work. So there's some nuance to it.
Mhm.
What do you think?
Yeah, I think it's a great question. And I think it's why I included the public mistrust in the final section, because I don't think, unfortunately, that this is the low-hanging fruit. Because I think although maybe a starting place is starting with individual conversations that we as individual providers have with our patients, I think it's going to take a broader cultural change, because I think we need to bring patients in and make sure that they know what is the culture about how we train surgeons. Because I think a lot of the public, they expect that, we go through some kind of training and we come out surgeons, but they don't really understand how that happens, how that process happens. They're not really aware of it. And we haven't really been educating them. So I think it's going to be a broader cultural change where we bring our patients into the discussion. And I think you can't quite do that until you've addressed their fear, because what you're talking about, we've all seen a patient who says, I don't want the resident to be involved, or I want you to do my surgery completely. Like, I know it's important to train them, but I just don't want them involved. But that really comes out of fear. And so I think it's going to take a broader cultural change. But I think as educators, we have to work towards that, because we can't continue to train surgeons without the public knowing that this is safe and effective, I guess.
Hey, Leah, great talk. A million questions come to mind, but I'm going to focus on just one. I know inevitably you're going to be a program director one day, and if you get pulled into a new program and you get to build it from the ground up, I feel like something we're always caught between when we're residents is service versus education, and the two are always at conflict. And I'm curious your thoughts about, if you could design the ideal educational model, how much service would you want residents to focus on, or would you purely want us just to be there to learn? I don't know, any insight on that?
Yeah, so I forgot to repeat the question before, but I'll repeat this one. And the question is, if I was to design the ideal residency program, what would my ideal balance be between service and education? And I guess my pushback, or my concern with that question is that I think we can't lose sight of the fact that service can be educational, and that we need to learn how to take care of patients And so even just being in the hospital, a lot of what we do is educational. And so if we get rid of too many activities that are service related, we actually may unintentionally then go so far the other direction that we've then lost the educational value of those activities. So I think probably just like most things in surgical education, it's probably a balance, right? And so like writing discharge summaries, at some point, how to do that skill, but you don't when you first get here. So if you come into residency and you never write a discharge summary, you never learn how to, summarize a patient's stay in the hospital, then you'll never learn that skill, right? So I think we have to be really careful about the balance, but I think there's a balance. And I think we're actually we're achieving that pretty well, maybe at the moment. So I guess that's not a specific answer to your question. But I think we can't lose sight of maybe ways in which patient care are still educational.
I see a hand up from Dr. Diab on Zoom.
Hi, Leah. I know you and I talked a lot about this, but since low-hanging fruit has come up so many times this morning, I should hope that we aim for high-hanging fruit. The fox sort of conceded the low-hanging fruit because you can get the high-hanging fruit. And when you were reviewing this, I mean, so much of this is the pressure is on us to perform, certainly public scrutiny, but also financially. I mean, we're just driven in different ways, and we're driven away from you all, and we're driven away from taking the time to educate. So when you were reviewing all of this, what did you see much about getting people to commit dollars to education outside of the institution? You were saying, well, who should pay for this? Should it be the department, the institution? We talk a lot about philanthropy. It's a relatively easier sell to sell to philanthropists the latest research that's going to cure a disease. How much work has been done, maybe even within orthopedics specifically, to get dollars set up in a foundational model so that we can take the time and hire the faculty that will have the time to do this? Did you see much of that in what you were reading?
Thanks, Dr. Diab. That's a great question. And I think, unfortunately, we're at still a really early stage in that process of getting dollars to fund education, because I just don't think that's been the main priority of how funding is being distributed. So certainly, institutions are funded by the government, by Medicare, to pay for resident education. That's been like that for a while. But I didn't really see anything about new innovative changes to how that funding is happening. If anything, maybe the wrong direction. But I think it's an important area that we have to focus on. But I didn't find any models so far of how those dollars are being used. I would say one example maybe of where, so in Canada, they've been implementing competency-based training in orthopedics. So in Toronto is where it started, and then they've really been using that across the country in Canada. And it involves, it's not time-based, and they basically assess residents throughout their training. And it's extremely expensive because to develop all of those assessments of residents, it takes a lot of administrative power and time. So Canada has certainly poured a lot of funding into that endeavor. And I think so far they feel like it's been working, but the question I think that remains is whether or not it's sustainable because it's extremely expensive.
Oh, great. Dr. Kim.
Thanks, Leah. It was a great talk and opened up a bunch of cans of worms. And I want to take the other question, other side of the question that Dr. Diab brought up, which is, why is it so hard for us to grab the low-hanging fruit? Because much of what you described as things that we should do, we've been advocating, pushing, asking for implement are actually parts of requirements for rotations. And the survey result clearly shows that it's not always happening. And this is a time of year when Dr. Vail and I meet with residents, and one of the things we always say, a broken record is, it's really important for residents to ask for that feedback. What went well? What could have gone better? At the end of the case, it's a good time, yet it doesn't happen. So it's not so easy to grab the low-hanging fruit. Perhaps the ABOS system that we're implementing will facilitate that, but there are no guarantees. So what would you suggest as ways to allow us to grab that low-hanging fruit more often?
Thanks, Dr. Kim. So I think there's a few answers to that question. I think number one, maybe going back to challenge number one and thinking about expectations and whose responsibility is it, and setting expectations around who's going to take the initiative. Because one of the things I mentioned is that when both parties are given the opportunity to take the initiative, often neither one will. So trainees may say, oh, well, the attending didn't take the time at the end of the case to ask me what went well, so I guess we didn't talk about it. And the faculty may not remember, or also be rushed. So I think clearly defining kind of who's going to take the lead and make that the expectation is one easy starting place. And then at the same time, I think that time pressures are real. And so while I say that this is like low-hanging fruit and easy, I think that's why I brought up the issue about compensation for teaching time and the pressures that are put on us from external sources, because those are real, and time is truly a limited resource. So I would say it's multifactorial.
Yeah, thanks. I just wanted to weigh in on the topic of money and what do we have to spend on this, and why aren't we spending money? We actually have a lot of money that's sitting on the sidelines and not being used. If we think money is part of the solution, then what are we going to spend it on? I mean, this will be like a carryover from the points you're bringing up. What would we spend it on? We now have 15 distinguished professors in this department. A lot of that money sits on the sidelines, isn't used, could be used for education. We support each section. They have discretionary funds. Some of that just accumulates. It could be used for education. And this is an indictment of the chair holders. I mean, I have one too. It's more of, okay, well, if that's the reality, and you've pointed out to us, what the shortcomings are, some of them, then how would we potentially use resources to address this? And that's a really good, interesting, and although it seems obvious, it's kind of an unanswered question.
Oh, I'll just follow up with, I think maybe one idea is putting resources into, thinking about people that are really interested in education and making that their focus. So, Dr. Levine talked about the national, surgical educators course every year. So, spending money to send people there and build up like faculty development, for example, is somewhere that we could put those resources into. Or again, then using resources to maybe create more time, especially for people who are particularly focused on education. I don't think it makes sense for everybody. I mean, I know that being in an academic institution, everyone's expected to teach, but I also think that probably some people are more inclined to want to be more involved also.
Leah, great job. One of the things I want to add to when people, always ask me that I want residents, not to be involved in the case, you do the case, and you guys hear my response all the time. They're part of my care. They have to be part of it over there. That's how I practice. And one of the things, to change public opinion is that there's a reason why all the top 10 top hospitals in the country are academic institutions, the residents involved in the care. There's a reason why we deliver excellent care, because there are residents involved in the care. That's one thing to change perception, because you don't want residents. Well, there are community hospitals that are not ranked in the top 50 in the country. They can take care of you. There's a reason why actually I have someone that actually have an MD degree to help me do surgery, versus someone else actually has as assistant. So that's how we kind of explain it. And I would make sure that the trainees, understand that you are part of the medical team. You are the one that actually help deliver the care so that we could be as good as we are. So don't underestimate it. And that's when patient asks it, that's how we respond to them. So thank you.
All right, I think we are just past 8:30, so we'll wrap up there. But Dr. Demetri, thank you. This was a great talk, inspiring, and hopefully we'll take this forward with us.